My name is Anjali Achrekar, and I'm currently serving as the acting U.S. Global AIDS Coordinator. And I'm just so pleased to welcome you today on behalf of our team at OGAC, as well as the interagency colleagues, to today's PEPFAR Strategy Vision 2025 listening session. We've organized each listening session by stakeholder constituency as listed here above. Today, we're really excited to welcome our civil society and community partners for today's listening session. And the format of each session will be similar in that we'll start with a brief presentation. We'll then go to a facilitated, esteemed panel of stakeholders and constituencies. And then we'll have moderated comments and suggestions coming from all attendees through the chat. And we'll end with a summary of key themes that we've heard throughout the session. And as noted, all sessions will be recorded and we'll be sending the slides around as well. So moving into the epidemiologic and PEPFAR overview, here we see the global HIV/AIDS situation. On the left, we see significant declines in new infections and deaths since 2003, and the global treatment cascade on the right. These collective successes are a result, in large part, to our collective efforts along the way to scale prevention and treatment for the people we serve around the globe. Looking regionally, we see Eastern and Southern Africa with the most epidemiologic impact as a result of controlled epidemics in many high-burden countries. Here we see trends in new infections and deaths along the top, the distribution of new infections by population in the bottom left, and resource needs, as well as the testing and treatment cascade and gaps. In Western and Central Africa, we see continuing declines. And again, the same types of graphs are illustrated here, so you can see the depiction across this region. And here we see Asia and the Pacific. Again, continuing declines, and we have concentrated new infections among key populations here. In the Caribbean, we also see continuing declines. Here in Latin America, we're at a relatively steady state. In Eastern Europe and Central Asia, we see increasing trends in new infections and deaths. Resource needs are growing here, and effective implementation of evidence-based policies and practices are critical to impact HIV in the region. What has remained consistent is the unwavering bipartisan congressional and presidential leadership and support of PEPFAR since its inception in 2003. And as you know, PEPFAR provides support in 55 countries around the globe, and our investments are aligned to HIV burden of disease, as shown in the graph here. Here's a summary of PEPFAR's latest program results. We have 18.2 million people on life-saving treatment. We've seen an additional 1 million in the past 6 or 7 months alone. We continue to make strides together in circumcision, orphans and vulnerable children programming, and reducing HIV new infections among adolescent girls and young women, among other indicators. Here we see trends over time of PEPFAR's budget, which is the blue line, and the increasing results for circumcision and treatment in the yellow and blue bars. Again, this just has up to our Q2 results for this fiscal year. Our commitment to treatment continuity and growth is clear, despite the peaks in COVID-19 as depicted here in peach. And we see significant progress toward the UNAIDS 95-95-95 goals Here are select countries across Africa that have completed the FEA, and we show results here, as well as community viral suppression in orange. We've made strides together on preventing new infections among adolescent girls and young women through DREAMS, which we're very proud of. And we continue to make progress and as well as see gaps in our key populations programming. We're going to go quickly here, but to show data in terms of where we are with the number of countries at epidemic control. And I want to just shout out to UNAIDS here. Much of the data in this slide deck are UNAIDS data. So again, we're going to sort of move quickly. But here we have a series of countries at epidemic control of HIV: Zimbabwe, Kenya, Malawi, and Lesotho. Ethiopia, Rwanda, Eswatini, again at epidemic control. Thailand, Nepal, Cambodia. Burundi, Cameroon, Cote d'Ivoire, and DRC. Burkina Faso, Senegal, Togo, Mali, Liberia, Trinidad, and Tobago. And here we'll show a series of countries that are near epidemic control of HIV. And these include Botswana, Haiti, Uganda, Vietnam, Guatemala. And now we'll show countries with declining new infections, but not yet at control of HIV. So these countries are not at epidemic control of HIV yet, and these include Angola, Ghana, Mozambique, Nigeria, South Sudan, Tanzania, Ukraine, Zambia, and South Africa. Again, noting that the y-axis is very different along these graphs. And again, these countries not at epidemic control: Tajikistan, Indonesia, Panama, Guyana, Jamaica, Dominican Republic. We'll take a quick look at some remaining gaps and opportunities as well as the end state. Again, showcasing data from UNAIDS in terms of distribution of new infections and by age and sex. I wanted to make two key points here. First, in sub-Saharan Africa, despite the gains, 52% of new infections are among 15 to 49-year-old females, even though they account for 24% of the total population. So we must continue to decrease new infections in this population. It's critical, particularly as we understand the youth bulge. Second, variability of coverage and accessibility of critical HIV prevention services for key populations across countries and regions persists. We must continue to focus on these key populations and address barriers that are preventing access and scale up of services for these populations. Here we see coverage in ART by adults and children over the last decade. And I want to make 2 points here. 40% of children living with HIV had suppressed viral loads in 2020 versus 67% of adults. And second, nearly 2/3 of children not on treatment are those that are 5 to 14 years old. COVID continues to be a vulnerability affecting the program and beneficiaries. We've been adapting the program for the past 18 months to not only protect the gains, but to continue to accelerate as well as help respond to COVID-19. By truly leveraging the robust platform that exists around the globe that PEPFAR investments have strengthened over time. Here we see that we're not alone in the fight, and what we want to depict here are HIV investments by funder in PEPFAR supported countries. So you see the series of countries. In red, this is PEPFAR investment. In blue, Global Fund. In gray, partner country investments. And in orange, other funders. And we see projected gross domestic product growth versus HIV prevalence in red, and economic problems that persist across the board with countries with high HIV prevalence, as noted in the red dots, as well as higher income status countries. One key component to our approach to sustainability is delivering services through local partners and countries, and communities rather. We currently have 55% of new funds going directly to local partners that are indicated across these three graphs in blue. This varies by country and by care and treatment, shown in the middle graph, as well as prevention, shown in the far right graph, where we see that less than 40% of new funds are going to local partners for prevention. So in the end, what does a sustained response look like? There are several factors here, and just to quickly review or go over a few points. First, we see a whole of domestic approach from government to community that's really responsible for successfully sustaining the epidemic control of HIV. Sufficient functional, technical, and managerial capacity, financially sustaining essential services, HIV service delivery integrated into the broader public and private care delivery systems, and robust public health response to monitor and track existing and emerging threats, and quality assurance. And so this brings us, with that backdrop, this brings us to where we are today in terms of our conversation related to the PEPFAR 5-year strategy development. We've started developing the strategy with your help since last fall, as bulleted here, and look forward to continuing to hear dialogue, inputs, and conversation from our various stakeholders through these listening sessions and more opportunities we'll be providing. Your input is critical as we develop this strategy together. This will not only feed into developing the strategy itself, but also into our Country Operational Plan 22 guidance development, as well as longer-term planning. This strategy that we are looking to develop together will be focused on achieving sustainable, equitable, and resilient control of the HIV/AIDS epidemic, ensuring support of global efforts to put countries on track to reach the SDG 3, as well as being closely coordinated with the Global AIDS Strategy 2021 to 2026, recently released by UNAIDS and adopted by the various countries, and Global Fund's post-22 strategy. Again, we need to make sure that there's complementarity in these. There are 3 proposed goals and a series of objectives. I won't read all, as you have been given this in PDF form in the meeting notice. But to quickly note, goal 1 is to accomplish the mission, 95-95-95, sustained, equitable, client-centered HIV prevention and treatment services, supported by these 6 objectives listed here. Goal 2 is to build enduring capabilities, resilient and capacitated country health systems, communities, and local partners. Again, supported by these 5 proposed objectives here. And the third goal is to broaden the base of support, partner for greater impact, burden sharing, and sustainability, along with these 5 objectives listed here. We've asked panelists and all of you to reflect on a series of questions. I'll hand it over to Billy Pick from USAID, Trista Bingham from CDC, and Sandy Thurman from ESCAC to facilitate the next segment of the session here. Billy, over to you.
Thanks, Anjali, and good morning, everybody. We're really privileged to be able to have everybody who's on the chat, and particularly our panelists at this point, who are, I think, a very good representation of the civil society contributions, as many of you in the chat are, and we very much value the input into the strategy that we're going to hear today. So without further ado, let me run through the panel section of this a little bit. I'm going to ask each of our panelists to respond to the first question. And David, I think you're going to put the questions, paste the questions in the chat so everybody can sort of scroll back and forth and remember them. And then they'll ask them to respond more broadly to questions 2, 3, and 4 as they see fit. At that point, we'll turn it over to Trista, who will facilitate further input, not so much a question and answer, but we'd like additional input because this is a listening session and we'd like to hear from people in addition to those who are on the panel. So that's basically, and then Sandy Thurman will do a report out on this. Again, this won't be the only opportunity to give input into it from either civil society or from any of our other partners. We remain open to any comments, input that you may have. So with that, I'd like to start by introducing my esteemed panel, many of whom I've had the privilege of working for many, many years. First, I'd like to introduce Brian Macharia, who is the first coordinator for health justice and human rights at the Health Global Access Project, which we all better know as Health Gap. Health Gap works to eliminate barriers to life-saving HIV treatment for people living with HIV. Our second panelist is Lillian Mworeko, who's the executive director and founding member of the International Committee of Women Living with HIV in East Africa. They do regional advocacy for women living with and by women living with HIV. Our third panelist, an old friend of mine, Midnight Poonkasetwattana from APCOM Foundation. APCOM works to impose the rights, to improve the rights of gay people and other MSM and SOGS people across the Asia and Pacific region. And next we have Greg Millett, who's the Vice President and Director of Public Policy at amfAR. You might remember Greg from being the opening speaker for AIDS 2020. Again, an old comrade from both the domestic side as well as the international side. Francesca Merico is the HIV campaign coordinator for the World Council of Churches, the Ecumenical Advocacy Alliance, and last but not least, Claudine Mukakimenyi, who's with the Christian Association for the Advancement of Young Women and works as a Dreams mentor in Rwanda. So with that, I'm going to ask each of the panelists to respond to the first question, and I'll start off with Greg. Greg, the PEPFAR Strategy Vision 2025 is aligned to the Sustainable Development Goals and Global AIDS Strategy. And the draft PEPFAR Strategy Goals and Objectives to the priority areas, are there areas that we want to address? Are there any missing or in need of refinement? So missing or in need of refinement. And what do you think of the overall draft strategy, Greg?
Great, no, thank you, Billy. And it's really an honor to be here. It's great to be a part of this panel with many esteemed colleagues, and wonderful to see all of our colleagues who are part of the USG. You know, I think that the PEPFAR strategy outline really is off to an incredible start. There is quite a bit that's here that many of us can chew on that could certainly bring us to epidemic control and eventually ending the HIV epidemic. Of course, it's hard when you're pulling together a draft document that's as short as this to really put in a lot of the nuance that's necessary to really help tease out exactly how we're going to get to some of these goals. So, you know, some of the things that me and my colleagues noticed that perhaps could be built out a little bit more are as follows. So the first is, you know, we were talking about, you know, getting to epidemic control. And one of the key issues to getting to epidemic control is to have sustainable art as well as sustainable PrEP. But we're not necessarily there yet. We do not have great interventions for sustainable art or for sustainable PrEP. And as we could see both domestically as well as globally, we see high numbers of people who are starting medication, but then we see these massive drop-offs. And these massive drop-offs, especially when we take a look at PrEP, where you see over and over again in various programs from Kenya to some parts of Thailand to other areas, South Africa and other places, where we see by 3 months of starting PrEP, you see these massive drop-offs. So how do we get to a point where we can actually sustain PrEP, but also sustain ART for people living with HIV? And that's something that I'm hoping that we could discuss a little bit more, because as it stands right now, we're not necessarily at a place where the interventions are very robust. We might have an opportunity with long-acting PrEP as well as long-acting ART, but there are also some issues there as well in terms of the degree to which people either might find it unaffordable or whether or not people will trust these new technologies or feel that these are things that they can or should have access to. I think another one of the issues as well is the degree to which the COVID-19 pandemic is going to dramatically impact everything. And as we take a look at the goals that we have for 2025, there's a part of me that really is afraid that we might be farther off target than we really think. And why I say that is that we already know that there's going to be unprecedented levels of poverty that WHO and others have projected over the next several years because of the COVID-19 pandemic. And it's going to disproportionately impact women and girls globally. We also know that COVID-19 is really being rolled out. The vaccines are being rolled out unevenly geographically. There's a really fantastic work by Kaiser Family Foundation that basically found that only 15% of populations in low and middle income countries are going to have access to the vaccine by the end of next year. If we don't have most of the globe vaccinated, and particularly those countries that are serviced by PEPFAR, how is that going to negatively impact HIV services, HIV programs, and the work that needs to get done, not to mention the issues of being HIV positive and co-infected with COVID, where we saw some data emerging from WHO in the last few weeks. I think the last comment is the degree to which community is tied in with the strategy. It's wonderful to see the efforts that PEPFAR is engaged in for community level monitoring, which I think many of us are very happy about, and we think is definitely a way forward to really understanding what's taking place on the ground and offering some opportunities for cross correction. But there also needs to be some places where we can have more agency by community as part of the PEPFAR program, rather than just reacting, but making sure that community is leading the way in terms of the funding that's being placed, particularly for key populations. We recently did an analysis where we found that most of the PEPFAR programming is going to groups that are not KP organizations. And there's good and bad that's associated with that. We don't want to malign those groups because they're certainly doing the work. But we certainly know from our experiences that, supporting organizations that are KP-led, you're more likely to erase some of the issues of stigma. You're more likely to have greater trust. You're more likely to get members of the population who you necessarily wouldn't have access to. So really just trying to figure out ways that we could elevate community and to make sure that we have community at the center of some of the things that we're doing, I think would also be helpful as we move forward with the strategy.
Thanks, Greg, and for touching on all 4 questions in one response. That was pretty amazing. That's what I love about you. Next, before we proceed, can I ask all the panelists to put on their cameras so that folks in the chat and online can see you? I'll take it that they're coming on because I don't have the entire grid. But next, I'll be asking Lillian, same question. Are the draft goals and objectives from PEPFAR the priority areas for the program to address? And is there anything that you see is missing or in need of refinement?
Thank you very much for this opportunity. And I would like to add my voice to my fellow panelists that has already elaborated more on what we see. I think PEPFAR strategy is coming at the right time, and this is the time when definitely we have the global aid strategy in place that is very clear and articulate around ending inequalities. And I think from a perspective then, it is very, very important that this strategy is very clear in terms of how it is going to contribute to ending inequalities, especially where we know that we are talking about inequalities that range from different perspectives, that we are talking about inequalities around gender, we are talking about inequalities around populations, geographical location, and therefore all those are important that one would want to see that the strategy is really strong, particularly in addressing and looking at issues of women and girls, but also particularly looking at the issues of adolescent girls and young women. And therefore, ending AIDS and a statement in the strategy to say that we shall be ending AIDS by 2030 is not just going to come by itself, but there has to be bold decisions that are going to be taken. And that means that in the strategy, would want to see new partnerships being mentioned, coming out strongly, but not only partnerships, but we would like to see partnerships with communities. Because we've learned, for example, from COVID, that until we bring communities to where they deserve to be, we are going to remain behind, we are going to lag behind. And therefore, our expectation is that the strategy is going to be strong on partnerships that are going to be created between PEPFAR partners and civil society plus communities. But we also need to see new strategies that are innovative. I would like to stress that and to request that we look at how have we performed in the past years. One of the greatest things that I think has happened that we all applaud you for and that we are happy about is the community-led monitoring. But to emphasize that the community-led monitoring, from our understanding, is supposed to help us get to the basics of how can we make service delivery better. And therefore, the community-led monitoring alone is not going to deliver the strategy to the goals and objectives that we want. And therefore, it means that we need to have a lot of investment in community-led organizations, community-led responses, and community-led approaches beyond the community-led monitoring. The monitoring helps us to monitor and assess. But for example, from the CLM, we've learned that there are gaps that we have been seeing and talking about for over a long period of time. For example, treatment literacy as one of the issues. So it means that now we must put a strategy that specifically targets communities, people living with HIV, key populations, women and girls, adolescent girls and young women, so that they are able to design, implement, and monitor programs and activities that help us address those issues. One of the key areas that I think comes out strongly in what you shared with us is that there's going to be people-centered approaches. So we would like to say that we need person-centered approaches that PEPFAR's new strategy is going to invest in. And what does that mean from a perspective? When we invest in people, we are looking at them from a comprehensive approach. But also it requires that when people help us to understand issues and priorities that impact them, like for example, communities have said there's a lot of unfavorable laws and policies where they are, where you want to take services. Because for example, when the strategy says we want to take services to where people are, the challenge is that you take services and we continue to take services because the policies are unfavorable, the environment is bad, there's stigma and discrimination, then we will not have services, increased uptake of services. And therefore, there is need to invest in communities so that they are able to address stigma and discrimination, to deal with human rights violations, and to ensure that the environment is favorable. So we would like to see in the next strategy, PEPFAR putting to scale resources that are targeted to these groups and communities. And I think it is also important that one of the gaps that we are seeing is that even where we see successes, best practices, and things working, what we are not seeing is that these programs are not put to scale. You can talk about, for example, the dreams which has shown that it works for adolescent girls and young women. So the question is that we continue to see young women and girls getting HIV infected. It is because the program itself is not put to scale in terms of reach, in terms of numbers, but also in terms of programs and activities that are targeted at these young girls. So our hope is that in the next strategy, all this should be put to scale because we have that evidence, we know it works, we have the tools, all we need is a more investment. And I think one other clear issue that is not coming out clearly that we hope that is a gap that should be addressed is that one, from where I'm seated, I think there's need to be a strong and separate goal that speaks to communities with clear objectives. And in that way, then would be more focused in terms of if really indeed we are saying that communities matter, communities are important. And when I talk about communities, I'm talking about all these communities of people living with HIV, key populations, adolescent girls and young women, people with disabilities, you can name them wherever they are. So if we really are clear and saying this is where we want to go as we decentralize as PEPFAR, then there must be a clear goal and objectives that are targeted to that so that when finally we are monitoring, we are able to see when we brought communities on board, what resources, for example, were allocated? How did they use the resources? What programs did they implement? Did they help us to bring about the change? I think that way we shall have, achieved more. And I think the final one, from my perspective, is the fact that we have seen the role of communities and what they have contributed in the past years. The time when PEPFAR brought communities on board, we very well know that there have been successes and that services have been able to reach people, but that we have also been able to, to tell where we are failing, where the gaps are. But since last year, I think we are beginning to see some kind of slow back in terms of how communities are engaged, how communities are participating. And I think one of the calls that we have is that there must be strong leadership. If we have to achieve and end AIDS by 2030, we need leadership that believes in communities, that will work with communities, and will make sure that there is a strong partnership that is meaningful and that is not tokenistic. So leadership is going to be very, very, very important, and there has to be an investment in that. And finally, to say that when all this is done, I think this provides us an opportunity that this is a one-time like we cannot say everything here. We are beginning a conversation, and as communities and civil society, we would like to continue engaging so that when we develop this strategy, we all believe in it, we all buy into it, and then we all go out to deliver on it. So community engagement at this level, we appreciate it, but we want it to be a continuous process until when we have a strategy and until when we start and end its implementation. And therefore, our call is, if you have not thought about it, that we would love that you have some civil society and community representatives joining the team that is developing this strategy. Over to you.
Thanks, Lillian. And with that, I'd actually like to bring in at this point, Claudine, since Lillian sort of called out the DREAMS project in adolescent girls and young women at this part. So Claudine, in addition to anything that you see is missing in the strategy, I'd like to take a look at question 4 for you about the inequalities, stigma, discrimination, and ineffective policies, and go back to what Lillian was also talking about, specific strategies that we could undertake as PEPFAR to better confront the challenge. Lillian?
Hello, everyone. Can you hear me?
Claudine. Hi, Claudine. Yeah.
Hi.
About
the strategies PEPFAR have prepared, I have looked into them, and I think everything is clear. What have to be done is to reinforce how the implementation of those strategies are being done on the field. We have to reinforce in that thing. And also, we have to do follow-up. As PEPFAR, you have to do follow-up if the implementation is going well on the field. Is there any challenge the people who are implementing those strategies are meeting with? If there is challenge, how are they doing? What are they doing to overcome the challenge? So when I go straight to the question 4, I think government, schools, traditional authorities, families all have to be, they have a part to play in addressing the structure drivers of HIV risk for adolescent girls and young women. The recommendation for PEPFAR is to support or supporting adolescent girls and young women means more than convening stakeholders. It also means ensuring that the stakeholders are engaged, informed, and share accountability. PEPFAR has included this in its strategies, but further contextualizing this for adolescent girls and young women who are facing varied politically will, community buy-in, and resources will mean looking at how the best leverage PEPFAR investments and relationships to drive this forward. We cannot afford to plow, we must leap. That is about addressing inequities. And about all of that, nothing for us without us. It means that nothing can be done to them without them. Nothing can be done to adolescent girls and young women without them. So HIV risk for adolescent girls and young women is further complicated by adolescent girls and young women often not having access to basic opportunities and needs like their male peers. The barriers to adolescent girls and young women access are cross-cutting and require integration that speaks to this. Dreams tries to do this, but this should be more intentional overall. So what I think PEPFAR can do, because I have read their strategy, and PEPFAR strategy should further expand upon the integration of non-traditional, non-biomedical prevention consideration that speak to the unique needs of those adolescent girls and young women. It is obvious that there is a disproportionate impact on adolescent girls and young women when it comes on accessing employment, education opportunities, which also drive their HIV risk. So this should be expressed more explicitly in the strategy. Addressing gender inequalities and protecting even further marginalized subpopulations are also critical. So PEPFAR should engage with local leaders. The local leaders' engagement will be important, but also adolescent girls and young women are also leaders in their life, for their body, for their decisions. They are also leaders. So and we are not all the same. Ensuring that adolescent girls and young women with varied life experiences are truly engaged in the design and targeting them will ensure the responsive programming. So those adolescent girls and young women should also help set the priorities for them, because if the program is for them, if PEPFAR is designing it, should also help to set the priorities. We have more than stories and challenges, we have solutions. So violence, especially sexual violence or gender-based violence, and its harming impact on women and children must be stopped. It must be called out at every opportunity, and we all must determine ways to address it more robustly. This epidemic on its own further drives the HIV risk of women and girls and should never be allowed to remain the law. So the recommendation is PEPFAR must continue its work in responding to and preventing violence, but it must be repeatedly call it out whenever possible. Anywhere you get possibilities, anywhere you get opportunities, you must be call it out. The PEPFAR strategy should be used to further amplify the significance of violence prevention and response. Stigma and discrimination around SRHR and harmful gender norms place adolescent girls and young women at greater risk at negatively impact communities. So here the recommendation for PEPFAR should consider using the strategy as a platform for calling these out boldly and leveraging its investments, partnerships to push for action and commitments coupled with accountability mechanism. So for these adolescent girls and young women should be empowered to make informed decisions without shame or fear. And the strategy is a way to elevate this messaging. Also, SRHR knowledge is for all. Adolescent girls and young women should not be bear the responsibility alone. So that sometimes you women, teen mother, like after giving birth, they are the one to this have to be there for.
Claudine, you're sort of cutting out a bit at this point. So maybe we can only hear like every other word from you at this point. So maybe we can go on to Brian, because are you back? Okay, can't. Okay, so we can't hear you at this point, but I think in the interest of time, we'll try to thank you very much for your input. And Brian, I want to ask you to also follow up on the issues of stigma, discrimination, and ineffective policies making our job more difficult, and what we could possibly do as PEPFAR to do that. For those of you who don't know, Brian, before he was at HealthGap, also worked with GALC, which was the LGBT organization in Kenya. So Brian, are you on? Maybe not.
Thank you. Thank you all. Good morning, good afternoon, everyone. Great reflections from the panelists. I think when you're thinking about the strategy, the PEPFAR strategy for the next couple of years, it is important, and we definitely appreciate the need to have ambitious targets and to really put to paper ambitious plans to be able to deliver us to the goals. But none of this will be able to be achievable without strong leadership and strong power to drive and to coordinate the achievement of these goals. And I think for us, I just want to take a moment to just acknowledge Anjali. Anjali stepped in to the leadership of the PEPFAR program at the onset of COVID. And we're really, really grateful. Just want to celebrate you for your service and for providing that leadership. But that being said, there is a type of political power that is activated through the congressional appointment of a PEPFAR coordinator. And for now, we are close to a year, I think a year, and we still don't have a permanent leader for the PEPFAR Global Program. And we're definitely seeing the ramifications of that concern. We're seeing with that there's been a significant decrease in resources. We're seeing the type of political engagements where countries are held accountable for not being able to put into practice and to activate community work, to activate resources that benefit community programs, to put into effect policies that eliminate barriers that impact access to services, has been very prevalent within this period. And so it is important for us to acknowledge that it is important for the congressional appointment of a global AIDS coordinator to be able to carry forward the implementation and the delivery of this strategy. I think it's also important for us to acknowledge that resources play a significant role. So where we talk about ambitious targets and ambitious plans, resources are supposed to complement that. And from the strategy, we're not able to see clearly PEPFAR's vision or PEPFAR's plan to ensure that resources are available to follow through in the achievement of this incredible objectives and targets. Over the last couple of years, we've been seeing a flatlining and a decline actually in terms of resources to various countries. And this is definitely taking a toll on the quality of care, the quality of services that our communities are getting. We're seeing a reduction in targets. We're seeing an under prioritization of various issues such as key population programming. With the end of KPIF, for example, we've seen key population programs have been under prioritized. The amount of resources to this program has significantly diminished. And going back to Greg's earlier comments, where resources are not just being received by key population-led programs, but also key populations competent programs continue to present a risk, because we know that the best way we are able to reach vulnerable communities is by funding communities themselves to lead the program, to drive the service provision component, and that has been significantly lacking for the last couple of years. I think when you're thinking about the next strategy and we're thinking about eliminating forms of stigma and discrimination and all these barriers, there's also a need to really rethink PEPFAR's approach to policy change. For the last couple of years, we've seen PEPFAR prioritize or support moderate elimination of barriers interventions. And now, as we're galvanizing efforts and strategies to meet the goals for 2025, we need to have very bold and very ambitious interventions to eliminate these barriers. And when you think about key populations, you're acknowledging that KPs are criminalized in a lot of African countries. And so while we're still thinking about innovating our biomedical components, access to services, retention, viral load suppression, we still have this animal in the room, which is communities are criminalized. And so we are not able to push that envelope any further than we already have without eliminating that problem. And PEPFAR needs to be a bit more intentional about supporting and actively supporting interventions that promote human rights, efforts that eliminate human rights barricades, criminalization issues. I think it's important for us to acknowledge that the bulk of PEPFAR's work in Africa is PEPFAR operates, PEPFAR implements its programs in an environment that is deeply patriarchal. A lot of African countries are deeply patriarchal, and because of this, we're seeing lots of issues around sexual and gender-based violence, intimate partner violence. And with the learnings we gained from last year, we saw that very prevalent through index case testing. And so it's important for us to, and it's important for the strategy to be really, really intentional about understanding these issues and funding these issues extensively, and empowering communities of KPs, communities of women to lead efforts of GBV, SGBV, and IPV in the context of HIV. I think there's been a general conversation around the integration of programs between lots of partners, lots of stakeholders at country level. Governments are very keen on integration of services. PEPFAR has been keen on integration of services as a way of building the sustainability of the program. But it is important for us to acknowledge that with the current gaps in the program, integration is not likely to be achieved, and it's likely to harm and undermine and pull back all the gains that we've achieved. Integrating key population programs in general facilities perpetuate stigma and discrimination. The health systems in various countries are not as advanced and structured as you'd see and expect in the developed world. And therefore, integration is the type of thing that is not likely to be achieved in present state. So we definitely need to acknowledge that and be very mindful of not putting to place interventions that are going to pull us back.
Brian,
I think
Brian, can I? We're like over time already for this portion of the segment, and we still have two other presenters. So I appreciate your input on this, and if there are other things, please let me know. Please let us know what you can, if you could, in writing or an email. But I want to take to heart something you were saying about the platforms that we have, as well as the challenge that we faced in the last year. So I'd like to ask first Francesca and then Midnight to think about over the next 5 years how the platforms that we built for PEPFAR are going to be able to lead to sustainable HIV and epidemic control, given the fact that we've had to address COVID this year. We'll probably have to address COVID next year and perhaps other pandemics. So basically it's around question 3, how should PEPFAR continue to leverage the platform that we have given this current state of the world? So Francesca, can I turn it over to you, and then Midnight for the last word?
Thank you, Billy, and thank you for the opportunity of sharing the faith sector perspective on the outline of the PEPFAR strategy, and also for these questions on COVID and the next 5 years. The faith sector comprises of faith communities, faith-inspired health service providers, faith-based organizations, and religious leaders. And I'm pleased to say that faith-based organizations have been included among PEPFAR essential partners since 2003, and we really hope that this collaboration will be announced with a new strategy, including through support of the PEPFAR Faith and Community Initiative and the PEPFAR UNAIDS Faith Initiative. I want to, before going on the COVID questions, just offer some remarks and comments around the goals and the objectives. We believe that to meet clients where they are and to find persons who do not usually intersect with medical system, we really must reach into communities, as been said before, including communities of faith, which are key to find people. And the same is to maintain and improve access to services. So for us, it's really important that PEPFAR and its partners continue to leverage the extensive reach, influence, and compassion capitals of communities of faith and their unique structure. In relation of Objective 3.4, that talks about supporting and utilize the unique assets and capacity of communities, including faith-based organizations. We really hope that this will include all the assets of the faith sector. So the use of places of worship to create demand for HIV services, and also to mitigate the impact of COVID, working with, in collaboration with various communities and religious leaders to change attitudes, and community outreach through faith community groups and community volunteers, and also strengthening the delivery capacity of the faith sectors. And regarding goal 1, so it has been mentioned by Lillian before already on the focus on delivering people-centered HIV prevention and treatment services. For faith-based organization, person-centered means bio, psychosocial, and spiritual approach to prevention, treatment, care, and support. And it's really this holistic model of accompaniment and care that is a strength for faith-based organization, and it shows in the high viral load suppression of some of the faith and community initiative best practices models. But we require support to better document results of this bio, psychosocial, and spiritual approach. Objective 2.1 mentions supply chain management, which really needs to be fixed in many countries. And this has been a constant problem for many faith health service providers during the past 18 months. And so supply chain management must be really a priority, and FBOs providing services need to be part of the supply chain distribution. And there is no scenario for us in which we can achieve the progress we want against HIV while systems for health are threatened by COVID-19. And so we really call PEPFAR on considering adding a specific objective on the role of PEPFAR platform in mitigating the effects of COVID-19 to continue achieving progress towards the epidemic control. We believe that PEPFAR should leverage its platform to support addressing COVID by leveraging on structures and community structures that are already in place. And we really feel that communities of faith are uniquely positioned to help countries respond to COVID. And both the PEPFAR Faith and Community Initiative and the UNAIDS-PEPFAR Faith Initiative are already working with religious, spiritual, and traditional leaders who are playing a very important role in engaging communities of faith and other traditional community to understand both HIV and COVID, raise community awareness and increase uptake of treatment and prevention intervention, and also adopt mitigation measure for COVID. We really feel that this important influence role of the faith leaders has to be strengthened and accompanied. We know that religion and spirituality play a very important role in nearly every community, especially in Africa, where almost 60 to 75% of the population regularly attend religious services. So this relationship of trust that is key for faith communities is also an important element for effective delivering of health messages into communities. So it's what we really hope that is going to continue during the next years. And Billy, if there's going to be time later, I would like to share some reflection around the stigma and discrimination and the role of faith to address the barriers to HIV services. I stop here because I know there is someone else who needs to intervene. Thank you.
Thank you, Francesca. Great points. And we'll see how much time we have left at the end when Trista is facilitating the other comments. But I want to give the last word to one of my old friends, Midnight, who's actually in Thailand at this point, I believe, in the middle of an emerging COVID epidemic there, and one that has impacted a lot of APCOM's programming in the Asia Pacific. So Midnight, over to you.
Oh, hi, Billy. Hi, everybody. Nice to see everyone here. Yes, we are in an extended lockdown. So I'm not sure how long this is going to be in the foreseeable future. But yeah, we're talking about resilience. And we know that key populations, community-based organizations have been really resilient in reaching the most marginalized and vulnerable in society who cannot access services. And they range from like health needs, shelter, food, PPEs, as well as other humanitarian work. We conducted a survey in Thailand last year during the first lockdowns with 8 community groups with 1,430 respondents. And even from last year, the respondents said like their income was affected, like over 90%, and over 50% did not receive governmental support and assistance, financial assistance. And this is for like a middle income country. And then that, of course, have the impact on the access to health services. The majority, or like 60, nearly 70%, were worried that HIV prevention and treatment services will be difficult to access because of imposed restrictions and travel mobility, particularly for people living with HIV, because they were worried about the supply of ARVs. However, they mentioned that because community-based organizations are able to fill in these gaps because they were able to pivot their services to be online or using courier services to then be able to then supply the medications. Respondents, even for last year, talked about the mental health issues, anxiety, depression, the helplessness caused by many number of factors, including joblessness and loss of income. And now with more and more people with COVID, there's a lot of fear now, even to go outside here. So the data, also shows that, how do we then deal with mental health issues within our programming? I think that hasn't really come out. Our previous panelists also mentioned about cases of domestic violence and also cases of gender-based violence, and that was also found in our report. So I think for PEPFAR, we should look at really asking what the community needs right now and how do you respond to the emerging and changing needs because of COVID-19. It is changing until we all have access to good COVID-19 vaccines, and the rolling out in our region is still not there, unfortunately. And we know that the rolling out will not be equitable. Particularly for people in HIV and people within the key populations. But we need that capacity strengthening right now more than ever. And in terms of leveraging the support of platforms that is already established with PEPFAR, USAID, in Asia Pacific region, I have to say that we did really good consultations leading up to this meeting with the other key population networks, including Youth Lead, the Asia Pacific Network of People Living with HIV, Asia Pacific Transgender Network, the Asian Network of People Who Use Drugs, Asia Pacific Network of Sex Workers, as well as APCOM, in terms of this consolidating feedback that we gave to Angelis and her team. But I guess just to say that, we know that there are, significant movements and changes that looking at involving meaningfully the key populations in these processes. But we also want to see that, how some certain issues that a lot of the panelists have already mentioned will be taken up and also be part of the monitoring, because we know that's where then it really matters. If we're not there in writing and if we're not actually measured, then we can be clearly missed out. And one of the things that came out strongly in those discussions is the capacity development and the core funding to community organizations to be resilient, particularly because of COVID-19. Thank you.
Thanks. And I want to thank all our panelists at this point. We could spend hours discussing all the issues and on this, but I want to encourage everybody. First of all, I want to thank everybody who spoke as a panelist, and in the interest of time, I want to turn it over now to Trista Bingham to try to facilitate some of the comments that have come in over the chat. We have a limited amount of time left, but again, thank you to all our panelists on this, and we look forward to hearing the facilitated chat from people in the chat box. Trista, over to you.
Great. Thanks so much, Billy. Thanks for moderating that session. Thanks to all the panelists. I won't go at, I don't think I'm going to address the comments in the chat. I think if anyone wants to speak and have it, present orally at this point, please put your hand up and I can unmute you. We are taking this is recorded and we're taking all of your chat comments with us as we consider the strategy. So please enter whatever you can. And then I'm looking to see if there's anyone who wants to make comments right now. Please keep them brief so that others can speak as well. Thank you.
Trista, I think we have about 4 hands raised if you go to the top of the participants.
Okay, so I'm looking and I
can go ahead and
yeah, please.
Amira.
It doesn't go to the top of mine. Are you good?
Oh, can you hear us, Amira?
Yeah, I can hear.
Yep. Please go ahead.
Can you hear me?
Yes, we can. Thank you.
Yeah, thank you very much. Thank you very much for allowing me to participate in this particular meeting. And thank you, PEPFAR, for what you are doing in Nigeria. But ending what I see in the field, because I work as a community mobilizer in the community, is ending
Amira, we're not hearing you. Is anyone hearing Amira?
In 2020,
we're having trouble hearing you.
We're having challenges with your connection, so yeah.
Amira, please try again.
I think we may need to come back to Amira.
Yeah, let's come back.
Privacy of it.
Amira, we're going to come
Yeah, the
Amira, we have
discrimination
to come
is
back
there.
to you. You're dropping.
Yeah.
Amira,
Okay,
we
are
are
you
not
here?
hearing
Are
what
you?
you're saying. We're gonna, no. So maybe try to find a better spot and then we're gonna come back to you, okay?
Okay, Roderick, we're going to go to you now. Roderick, are you able to speak? Okay. Catherine, are you able to speak?
I think I am. Thanks,
Great.
David and others. I will try to be brief, but I did want to give one note of appreciation for having this call, as well as what the discussants have brought out on sort of inequities, and particularly sort of looking at scaling up and the urgency around both clinical and community-based interventions. I think that's something that came out really nicely, and wanted to thank participants for that. I really feel like the one thing that's sort of missing, and I know it's in the strategy, but considering what the UNAIDS and PEPFAR data has told us, we really need to start thinking about some specific goals and outcomes for children. And this isn't just about a treatment or prevention gap. This is really about a quality of care gap. And there are places where PEPFAR can really emphasize and use its strengths to advance this work quickly with real impact. I think when I think of this, I think of the innovations. We've talked a lot over the past 2 years about children and the need for pediatric formulations and point of care EID, but those are still kind of slow on scale up. Some of that because of COVID, some of that because of commodity interests. But even more attention on pregnant and breastfeeding women and prevention there with all what's happening with PrEP, with the introduction of multi-purpose prevention technologies. There's a lot of opportunities to be innovative in this sphere and not just try to scale up what we've already done in the past. Equally, PEPFAR's focus on data. So much has been done on data analysis of other populations, and particularly pregnant women. We understand now more than ever where we're sort of failing pregnant women, but we haven't done the same analysis with children under age 15. The data we collect and analyze hasn't been done with the same umph. I'd also emphasize differentiated service delivery. A lot of the comments noted that adolescent girls and young women aren't cookie cutter, and I think that is definitely in this realm when it comes to younger children, school-age children, also young mothers. I think that's something that's gaining more attention that can be dealt with. And then finally, I just want to note the OVC work, because it hasn't come up a lot in this discussion, but I think that recent report on orphanhood and COVID really shines a light onto the unique needs and how these things can sneak up on us. And so I think as we look in the next strategy, how we address those support and care services for children that are vulnerable and orphaned is something that I think needs some robust discussion. And then my last comment, just because it came up a little bit in the chat, is I think this idea that the strategy really does need sort of a North Star, a sort of vision statement. The last strategy was really focused on epidemic control, and while it wasn't always everyone's favorite way of looking at things, I think it really made the decision making around not just interventions we choose, but operational models really clear. And so I think as you're looking to develop the strategy, kind of leaning into that sort of vision, that North Star, that everyone can look at all the great things you have under all those goals and objectives, but really understand what the common accomplishment, what our mutual goal is, I think will be really helpful as we move ahead.
Thank you, Catherine, so much for those very valuable comments and speaking to children and adolescents. So I'm going to, thanks for your comments, and I'm going to switch to Richard Lusembo. Richard, can you speak?
Yes, please. Thank you so much, Trista, and everyone for organizing this. Thanks so much, and please for this and other panelists. I just want to speak to things. One is around the vaccines. We know for sure that, for example, in the Global South, vaccines are still not accessible. Just is in case these are available. They engaging different governments, especially the Ministry of Health, to also fast track community health workers, especially when we are talking about epidemic control, because right now they are not a priority, and yet if really we are to achieve epidemic control, we need them to continue doing their work, but in a safer way. My other comment is around the issue around, again, community health workers. And we know for sure in some countries there is a whole policy blockage in terms of how they are to be paid. And again, if you're talking about epidemic control, it would be really important to see that we work towards formalizing their work to ensure that at least they're able to take on work with a paid living wage. Because right now that's still not possible. And this is again to look at how are we going to sustain the different programming that we are doing. And I think if this is considered, it will be really important, because then they can do their role without necessarily feeling like they'll be laid off or something like that. And also the other last one is around the KPIF. We have learned a lot from KPIF, and there's so many things that need to be taken on in terms of learning that actually if communities are empowered, they can really help us to reach communities that we have for a long time failed to reach. So I'm just really wondering the fact that KPIF is done and we have a lot of learning from it as we plan this new strategy. What funding streams are we thinking of to put in place to ensure that the issues that we're able to actually achieve during the KPIF, we do not lose them at all? So I really want to thank you, and thanks for organizing this. Thanks.
Thank you so much, Richard, for mentioning the care and protection and support for community health workers, and also KPIF, which is near and dear to my heart. Thanks so much. And I would like to go to Amanda next. Amanda Benda.
Okay, thank you so much. I was trying to unmute myself. So I have 4 quick.
Amanda, we can't. Amanda? Amanda? Amanda, we don't hear you. Amanda? Amanda, we weren't able to hear you. We've taken you off video. Can you try again? Just one chance.
Can you hear me now? Yes, better?
Yes, please go ahead. Be brief. Thank you. So I'm hearing Amanda. David, are you unmuting her?
I think somebody
her connection isn't good.
Somebody keeps
Go ahead, Amanda.
muting me. Okay. So quickly, I think the first point that I want to raise is the recognition in the new strategy to really focus on ensuring that it's not going to be a linear, but a cyclical kind of like approach that clients are taking in terms of moving in and out of the treatment cascade. And so just taking the linear approach to 95, 95, 95 as a means of achieving epidemic control, I think really needs to be redefined in the new strategy, because obviously we know that a lot of clients are moving in and out of care a lot and leaving them vulnerable to advanced HIV and of course death. And in that sense, the strategy needs to focus then on prevention, diagnosis and treatment and care of advanced HIV, and just put a lot of emphasis on long-term continuity and care. The second point I want to quickly raise is on going beyond innovation, because in one of your objectives you highlighted that, but we want to emphasize that it should be beyond embracing innovation, but really highlight clear commitment to accelerate the introduction and adoption of prevention, diagnosis, and treatment new tools. That really needs to be something that should be highlighted. The third quick point is, of course, on health systems, leveraging other partners, coordination and harmonization of their investments in health systems, like HRH, supply chain has been mentioned, but also lab and diagnostics and the M&E element. And the last point that I want to highlight is PEPFAR in the new strategy really needs to also articulate and revisit perhaps its transition and sustainability of programs in countries in collaboration, of course, with the governments and other global health initiatives and financing institutions. Thank you so much.
Amanda, thank you for the brief and very important comments. Appreciate that. And sorry if we were messing up with your muting. And then Tatenda, would like to go to you next.
Okay, thanks so much, Trista and colleagues. Mine is also a point of appreciation, particularly with the support that countries are also receiving with regards to the stigma index. So in Zimbabwe, we appreciate also the support that we are getting from the PEPFAR coordinator and UNAIDS for us to measure the prevalence of stigma and discrimination among people living with HIV. I think this is critical, but what is also more important is also to have advocacy-related components that when we do the survey, we should also have follow-up on issues that are raised in the survey so that they are addressed. It also takes in issues of the faith components and everyone else to ensure that we remove stigma and discrimination. And then the other issue is one of the things that keeps on boggling us with regards to the user fees. I know it might not necessarily be within the armpits of PEPFAR to push, but at least the funding from PEPFAR should be used to push local or national governments to remove user fees because they also become inimical to the PEPFAR investments. So those are my two submissions at the moment. Thanks a lot, colleagues.
Thank you so much, Tatenda. Appreciate very much. And I think we don't have much time left. I want to try Amira one more time. Just, I see there are two more hands up, but let's try Amira real quick. David, can you unmute Amira? I can't seem to do it.
Yeah, I also can't seem to unmute her. I'm not sure.
Okay.
Something on her
So
side.
Right. So let's go to, I see Samantha, please, just very briefly.
Absolutely. Thank you so much. I just have one brief point.
Hello.
Thank
Hello.
you for
Hello.
opening up the
Don't
floor.
hear me.
Yes.
Hear me.
Yes.
Hello.
Yes, can you hear me?
Yes, we can. Thank
Okay.
you.
Great. Thank you.
Okay, we're going to let Samantha speak briefly, and then whoever else is trying to get, I'll try. Over.
Okay. Thank you so much, Trista. I'll be very, very quick. I just have one bullet point that really that builds on what everybody else has said. I'm so grateful for everybody's comments today, specifically when speaking about the policies and the other factors that limit PEPFAR's success in the programmatic sense and in the service delivery sense. It's really important for PEPFAR to lead the implementation of President Biden's January 28th presidential memorandum revoking the Protecting Life and Global Health Assistance policy. Beyond just updating the COP21 guidance to say that the policy is no longer in effect, we need active participation and guidance from PEPFAR at all levels, including implementing agencies, headquarters, and missions, so that partners in country are really supported and understand how best to cease implementation of the policy and mitigate its effect on service delivery, on access to services, on integration, et cetera, as we know the policy has impacted all of global health assistance, including PEPFAR investments. So that's all that I would like to say, and I really welcome and support everybody else's comments. Thank you so much.
Thanks so much, Samantha. So we have Philip is the last hand up, and then Amira. Amira, I don't know if you were trying to get in before. Can you speak? Let's go to Amira.
We're having trouble unmuting Amira for some reason.
I know, it's strange. Okay, Amira, one more time, and then sorry, please put any additional comments in the chat. One more time, Amira. Okay, Philip Uma, please, let's unmute him.
Hi, good day, everyone. Can we all hear me?
Yes, please go ahead. Thank you.
Okay, so I'll be very quick. Mine is just to speak on some few points. They need to actually implement effective strategies for service provider trainings. And then I'll actually suggest a resource platform that is actually going to promote linking and learning for key populations as well, who are also service providers. You know, I'm also aware of PEPFAR platforms for trainings and capacity building programs. But we also know that we can't all train a whole lot of people at the same time. So if we have like a resource platform where which of course is going to be virtual, where we could just jump in and out at any time to get certain resources and knowledge for the work that we do, that would actually help. Then also if we could try to individualize try to individualize HIV programs so they are more responsive to the needs, particular needs of key populations and their subgroups. Speaking in respect to the needs of persons living with disabilities. And then also, I think at this point, it's actually very, very key if we improve our feedback mechanisms for usage of certain prevention and treatment tools or strategies, especially for adverse drug reactions, because we've had certain situations where certain clients react to certain drugs, but then they tend to report, but then I think there is actually a blockage of the information passing through to the right channel. So if we could actually make that more effective, that would actually help. So basically, that's just it for sake of time. Thank you.
Thank you so much, Philip, for those excellent points. And I think we're really late. I think Sandy, are you willing to
Trista,
summarize?
this is Anjali. I'm just going to come in quickly and then pass off to Sandy to summarize and close us out. So I just want to note 3 points, because there's a lot of really important feedback and input coming in, and we don't want to prevent any of that. We want to just make sure more is coming. So we'll do 3 things. First, please note that whatever chats have been, or whatever comments have been written in the chat, we are documenting that, and that will be included. Second, we will issue a formal process online so that written feedback can come online as well. So keep your eyes open for that. And third, I think we'll offer another session like this, a listening session for civil society and communities, just to create another opportunity for more feedback and input. We regret that some of the challenges we've had with technology, et cetera. So we'll do another session. So more to come. And Sandy, over to you to close us out. Thanks.
Thanks, Anjali. And so let me just run through this. We've got an incredible amount of information, so I'm delighted that we're going to, be able to continue this conversation at another time. But first, let me offer thanks to Billy and to all the presenters, particularly our stellar panelists. It feels a little more like a family reunion than it does like a listening session. So it's great to see everyone, and I want to thank everyone for joining. As Anjali mentioned, we have note takers who are capturing everything. So if in my very brief synopsis, so since I have 8 pages of notes in about 3 seconds to do this, just know that all of this has been recorded and can be captured. If I missed anything in the synopsis, please just shoot me an email and we'll correct this. This is the beginning of the process, and you all will have a lot more opportunities to engage. So this won't be perfect, but it will be just a short synopsis. So let me just run through some of the themes that I picked up in the notes today, and that we'll talk about again. First of all, we started with Greg, who talked about and noted the need for sustainable AR and PrEP. I think we all agree with that, and we probably need to define that with greater specificity. So that's something that we can talk about as we go forward. I think everyone, or almost everyone, has mentioned that we very well might be underestimating the degree to which COVID-19 is going to impact us during the next 5 years, or at least the beginning of the next 5 years of our strategy. And we might want to spend a little time focusing that and incorporate that, because there's no way that these two are not, going to be integrated. So we need to talk about that. Vaccine inequity was another comment and another theme that came up a couple of times, and the need for us to focus on the capacity of those at risk for HIV to be able to access vaccines. So that was important. There was overwhelming support that we need more agency by community and direct investment in community and community-led organizations. And that was a theme, and I think we need to be a little more specific about that in our conversations. We talked about community-led monitoring, and that it's good and not enough. That sort of leads into our investment in communities, and we'll have more conversation about that. The need for people-centered approaches was brought up several times, and putting people at the center of all of our approaches. We probably can talk more about that and be a little more specific about that. The need for a separate goals and looking at the impact that community-based organizations and communities as partners are actually making. So I think that's something for us to consider. We talked about specific consideration on young women and girls, and I think that's extremely important. And so we'll talk about that more as we go forward, and about calling out, using the strategy to call out issues like violence against women and girls. So the issue of violence is something we can talk about and look at again with you all. The need for strong leadership was referenced a couple of times, and I think that's important in our need to develop leadership, particularly at the community level, and support leadership at the community level. We can talk about that more as we go forward. There was comment about clarity of resources and sort of defining, it's great to have a strategy, but what about the resource piece, and how are those tracking? So more good need for, opportunity for conversation. I think one of the important things that was mentioned is the need to refocus on ambitious policy changes to reduce barriers to access to care and services. And that's something that I think we ought to focus on and have more conversation about. I liked the comment about, and it was sort of in a theme in all of this, is the challenges of integration of services for key POPs. Key populations. So again, something we need to make sure as we evolve, that we're not leaving anyone behind or separating services for people who need specific kinds of services. We certainly can't leave that out. We talked about again the need to meet clients where they are. So client-centered, client-focused, to use existing structures like faith-based organizations to do both provision of services and outreach to communities, and to leverage that existing architecture and those existing institutions for not only doing our work in HIV, stigma and discrimination and services, but also in COVID. So beginning to think of how we use the PEPFAR platform as we go forward to do our work in COVID, and how those are integrated and coordinated. We talked about the need, again, to strengthen community capacity around evaluation and monitoring. A couple of people brought up in the chat the need to not forget tuberculosis, HIV and tuberculosis, and the intersection there. Also talked about community health workers and the need to support and sustain the community health workers that they have, particularly in the context of COVID, and again, to really take a look at investing and programs that serve and are led by key populations. I think those were the biggest themes that I captured. I mean, again, there are a lot of pages here, and the note takers have been madly taking notes, and we have recordings. So I hope I haven't left anything out. That's about as quick as I could go through these. I just want to thank you all for being with us, and thank you, Anjali, for giving us another opportunity to meet. And Anjali, do you want to say something else, or you want me to close? Okay, I'll go ahead and close. Again, thank you to the presenters. Thanks to all the participants, those of you who wrote notes in the chat, Billy, to you, David, all the team at PEPFAR for your great work. And we look forward to chatting with you all again. Over and out.
Thanks, everyone.
Thanks, Billy.
Thanks, Trista.